Hi everybody. So today I'm going to talk about Alzheimer's disease. Okay, let's go ahead. I'm going to start with question number 1, which I think is a relatively it's a relevant, clinically relevant question, but we may not know a lot about. And the question number 1 is, how do you evaluate driving risk in patients who are suffering from Alzheimer's disease? We all know those DMV paperwork that they bring for you and they ask you, okay, can you please fill this for me? And a lot of times we wonder how to evaluate driving risk in patients who are suffering from Alzheimer's disease. So I'm going to tell you a little bit about two ways that two kind of scales that they have used, and they have looked into whether they are associated with driving risk and how we can use it. I'm going to tell you one fancy scale and one simple scale. Let's first start with the fancy scale. This is the fancy scale, clinical dementia rating scale. This is a scale that you will need a clinician who is trained in using this scale. This is a clinical interview, and if you do have access to somebody who is trained to use this, these are the scores that you can get. You can get a 0.5, which means they have very mild disease. You can get 1, which means that they have mild disease. 2 means moderate disease, and 3 means severe disease. The thing which is very important in this rating scale is that even low scores, so those who get 0.5, roughly around only around 75% of them will pass a road test, which means that 25% of them will fail. Those who score 1, around 50% of them will pass, which means that roughly 50% of them will fail a road test. So even very mild levels of Alzheimer's disease are associated with increase in driving risk. Now, this was the fancy one. How about the simple one? The simple one is something that I'm gonna bet that we all know how to use. And that one is called MMSE. MMSE equal or lower than 24 is associated with increased risk. So you can easily do this MMSE if they are scoring above 24, which will probably mean they have very mild disease, if any. Then that would mean that, okay, they may not have a very high risk, versus if they are scoring lower than 24. And this is just personal opinion. Whenever in doubt, you can always check that option of, they need to be road tested again. So that way you know that they have been evaluated for their driving ability very well. So that was question number 1. Let's go to question number 2. Question number 2 is, what are the differences between causative mutations versus disease-conferring mutations for Alzheimer's disease? I'm going to repeat it one more time. What is the difference between causative mutations and disease-conferring mutations for Alzheimer's disease? So let me tell you a little bit about them. So these 4 mutations are mutations that are all associated with increased risk of Alzheimer's disease. Now, apolipoprotein epsilon 4 is the one that you probably have heard of a lot. There is presenilin 1, presenilin 2, and amyloid precursor protein. Now, the last 3 are causative mutations. What does it mean? It means that if you do have one of these 3 mutations, that means that you are going to get Alzheimer's disease. These are autosomal dominant mutations, so if you have it, you are going to get it. And basically what they are is that these presenilin 1 and presenilin 2, these are proteases, and the amyloid precursor protein, as you can guess, is the precursor to the amyloid protein. Now these two cut this one. Now if they get mutated, if each of these get mutated, what will happen is that instead of cutting the precursor protein in the right place, they will end up cutting it in the wrong place. And you will end up with amyloid beta 42, which is the protein that accumulates in those amyloid plaques in Alzheimer's disease. So these three are causative. If you have them, you're going to get it. However, the apolipoprotein epsilon 4, which is basically an allele for the apolipoprotein, and it's pretty common, 25% of the population have it. If you do have this one, it means that you have an increased risk of Alzheimer's disease, but there's no guarantee that you're going to get Alzheimer's disease. So both in PRIDE and in board exams, they might play with these, ask the question in a way that it means that you need to answer with a causative mutation and then put the apolipoprotein epsilon 4 there for you to get confused, or vice versa. Okay, so that was question number 2. Question number 3. Question number 3 is about the medications that you can use in severe renal and severe hepatic failure. And I'm going to ask it, it might be kind of funny, but by the end, I'm going to tell you why I'm asking it this way. Name one commonly used antidepressant and one acetylcholinesterase inhibitor. If you remember, they're used in treatment of Alzheimer's disease. So one commonly used antidepressant and one acetylcholinesterase inhibitor that are contraindicated in severe renal and severe hepatic disease. Now, why do I ask it this way? Because I usually like to memorize the exception than the rule. So most of the commonly used antidepressants, you can use them both in renal failure and hepatic failure. You may need to be more cautious about the dose, but you can still use them. There is one commonly used antidepressant that you can't use it. It's contraindicated. What is that commonly used antidepressant? Can you tell me? Here is that commonly used antidepressant, duloxetine. Now, among the medications that are used for Alzheimer's disease, there is also one that is contraindicated in both renal and hepatic failure, severe renal and hepatic disease. Do you know what that one is? That one is called galantamine. Now, keep galantamine in mind because we're going to discuss it in a second again. Let's go to question number 4. And that one is, how do you choose between the 4 medications that are approved for Alzheimer's disease? And I'm going to show you the 4 medications here. These are the 4 medications that are approved for Alzheimer's disease: galantamine, donepezil, rivastigmine, and memantine. You may have noticed that these 3 are acetylcholinesterase inhibitors, and this one here is an NMDA antagonist, but they are all approved for Alzheimer's disease. Now, how do you choose between them? So I have already told you a weakness of galantamine. So let's cover galantamine. What was the weakness that we talked about? Let me tell you one more weakness as well. We talked about how you can't use it in renal and hepatic, severe renal and hepatic disease, right? So they can either have severe renal disease or severe hepatic disease. You can't use them. And a lot of elderly patients may have one or the other. Now, it has another weakness, and that is it has only been approved for mild to moderate Alzheimer's disease, which means that you cannot use it for, you potentially can. There are a lot of studies that show that all of these acetylcholinesterases have similar efficacy, but it's not FDA approved for severe Alzheimer's disease. And I usually prefer to prescribe something that is FDA approved rather than prescribing something that I'm using off-label, even if I have evidence that it works well. So let's cover galantamine because it has already 2 weaknesses, It may be, there may be circumstances that we decide it's worth it, but right now it already has 2 weaknesses. So let's cover that as a common medication that we use. Now we are left with donepezil, rivastigmine, and memantine. So let's say it's a patient that has just been diagnosed with Alzheimer's disease. In that case, you may know that memantine here is only FDA approved for moderate to severe Alzheimer's disease. So then you would think that, oh, so maybe I need to cover this one as well, if this is just the beginning of treatment. Now we are left with 2 medications, donepezil and rivastigmine, and the question is, which one do you use? Now I'm gonna bet a lot of people who are watching this are gonna say, I don't know why, but I usually use donepezil. Like people most of the time use donepezil. And that's not wrong, but let's look at why that is. Why is that? And if there are exceptions to that general rule, places that we may want to prefer using rivastigmine versus donepezil. So the main reason we usually do use donepezil as kind of like a first line is because it has lower GI side effects compared to rivastigmine. GI side effects like nausea, vomiting, diarrhea, and such. So it's more tolerable. So that's why we usually prescribe donepezil. Having said that, there are rivastigmine has 2 strengths, and that donepezil doesn't have. Donepezil has 2 weaknesses. Number one weakness that donepezil has is that it affects 2D6 and 3A4. So if you do have a patient who is on multiple different medications, some of which are going to be affected through 2D6 and 3A4, then you probably want to go with rivastigmine because it has a lower risk of interacting with those medications. The other thing about rivastigmine is that unlike donepezil, it has also been FDA approved for dementia in the context of Parkinson's disease, meaning a patient who has first developed Parkinson's and after a while, as the progression, as part of the progression of Parkinson's disease down the line, has also developed neurocognitive disorder, or as it used to be called, dementia. So rivastigmine is also approved for dementia in the context of Parkinson's disease. So if you specifically have a patient in that context, you may want to consider rivastigmine. Now, does that mean that donepezil doesn't work? Probably not. It's just not FDA approved. So that's pretty much for mild to moderate disease. Now, if their disease progresses to moderate to severe, then memantine comes into picture. Actually, there are combinations of donepezil and memantine that you can use together if you have a patient with severe Alzheimer's disease and you want to give them both of the medications together. Okay, that was question number 4. And the last question, question number 5. What is capryridine? Had you even heard the name of capryridine? What is capryridine? Capryridine is has been approved by FDA as a medical food. What it basically is that it's a source of ketones. And the idea about ketones and Alzheimer's disease is that the cells that have already been injured because of all of the amyloid plaques who are around and also tau tangles, they have a hard time using glucose. So it might be easier for them to use ketones. So if you give them a good resource of ketones, they may be able to survive a little bit longer or perform a little bit better, while the person already has some neurons. So that what that basically means is that this has been approved for mild to moderate Alzheimer's disease. So if we go back to the list of medications that we have, let's say you have somebody who has mild to moderate disease, you might want to give them donepezil or rivastigmine based on whether there is like drug-drug interactions or such. So you might want to give them donepezil or rivastigmine plus capryridine. And as they progress into severe disease, then you may want to use like donepezil or rivastigmine plus memantine. Now this one needs prescription. It's a medical food approved by FDA as a medical food for people who have mild to moderate Alzheimer's disease, and it's called capryridine. Yeah, that's it. Have a good day. Bye.